Thanks everybody for coming to the Spine Conference. I don't know where everybody is. I think that's where they are. See the picture? That's yeah, that's Outer Banks. That's North Carolina. So they're probably all on vacation, I assume.
Near Duck.
Yeah, I think it is near. Yeah, I think it is near Duck. Okay, so today this topic is diabetic peripheral neuropathy, and you may say, well, why are we going over diabetic peripheral neuropathy? You're a surgeon. Well, I have my own reason, and my reason is the red herring. So, Dr. David, do you know how the red herring works? You ever go hunting and use a red herring? Or you ever been chased by the police after killing somebody? Well, what they
generally not.
So what happens is that if the hounds are after you, and you take a red herring, a dead fish that doesn't smell so good, red herring, and you throw it across the trail, the dogs go after the trail of the red herring, and not the fox or the convict or whoever they're chasing, so to speak. So that's a red herring. It takes you off the trail. So the reason why I'm telling you about the red herring is I think quite often when I'm in the office and patients are sent to me for radiculopathy type symptoms, neuropathy type symptoms from compressive lesions in the spine. Well, it's not from the compressive lesion in the spine. It's a red herring. It's throwing me off the track. And what's the red herring? Diabetic peripheral neuropathy. So I think quite often in the office, I see diabetic peripheral neuropathy, and you may say, well, who cares about diabetic peripheral neuropathy? My issue is I think spine surgery gets a bad reputation, and the reason is quite often the wrong surgery is performed. Patients don't need surgery. They don't have a spinal problem, so they have the surgery that wasn't necessary, and they don't do well. So I think if I understand problems that mimic spinal conditions, I'll be able to treat it better. So those are my thoughts. So you guys know what this is? So the blue circle in 2006 by the International Diabetes Foundation or organization said this is the symbol for diabetes. The universal blue circle. Okay, I thought maybe you guys like that. So
we're colorblind Oreo fan.
O's.
Everything's great.
So diabetes. So what? Who can say a couple things about diabetes? Here's some things: you're always tired, frequent urination, sudden weight loss, wounds that won't heal, sexual problems, always hungry, blurred vision, numbness, tingling in the hands and feet. That's what we're going to discuss. Always thirsty, vaginal infections. Anybody want to add like general things about diabetes? And it can do all sorts of things. It can cause all sorts of problems, and it's a very prevalent problem in our society. So you say, well, how common is it? In general, it's about 9% of the population has diabetes. It's a lot more common as you get older. So you can see over the age of 60, it's 23%. So almost a quarter of all people have diabetes. So it's very, very prevalent. Male, female is about the same. Hey, Pete. Kaloston. Kaloston Kiro Barayoti. So, Pete, today we're going to talk about, it's not surgical.
What's it?
It's diabetic peripheral neuropathy.
Okay.
So it's a very common disease. I'm sure you see it in the office all the time.
Unfortunately,
Yeah, unfortunately. And I think as a surgeon, we should know what mimics surgical problems so we don't do the wrong operation. So, and it's so common, that's why I'm going over it so we can learn about it. So as far as race is concerned, more common amongst blacks than whites. And it's a very expensive problem in our society. So the main disease processes that occur from diabetes, and this is very brief, retinopathy, nephropathy, kidney abnormality, a peripheral neuropathy, that's what we're going to discuss. You can have a stroke, heart disease, and autonomic neuropathy. We'll go over that. So there's two types of diabetes. In the past, we used to call them juvenile diabetes. Type 1 was called juvenile diabetes or insulin-dependent diabetes. Now they just call it type 1. And it's a problem where you don't have insulin. So the pancreas doesn't make insulin for whatever reason. So the insulin is necessary because it drives the glucose from your blood system into your body, into your cells and your muscles, whatever needs the glucose to power our body. the insulin drives it in there. And if you don't have the insulin in the first place, your pancreas doesn't create it, that's type 1 diabetes. And quite commonly, it starts in a young age, like sometimes childhood. So the glucose goes into our bloodstream, and then the insulin goes in, and then we need the insulin for the glucose to drive into your cells. Now, the second type of diabetes is a lot more common. It's type 2 diabetes, and we used to call it non-insulin dependent diabetes, and we used to call it adult onset diabetes, but now I think everyone just says type 2. And how many people are type 1 and how many people are type 2? 90% are type 2. So the vast majority of people are type 2. And it happens is you gain weight. So how do you gain weight? How do you gain weight, Cammie? Eat too much and not enough. Not enough. What's the thing you do? The class you do? Body pump. Not enough body pump. Not enough or running. Not enough body pump or exercise. And sometimes genetically, you inherit genes from your parents that make you hungry. That's my problem. I got to blame my parents. It's my genes, because all the Greek food too. I mean, how can you say no to pastitsos, spanakopita?
Mine's it's a glandular problem.
Glandular problem?
Yeah, the salivary gland.
But if you smell that hot dog at the baseball game, it's we all have our issues that cause type 2 diabetes. So where is diabetes? Where does it travel? Where is it? Well, if you look at the incidence, it's a lot higher in the southeast. I mean, pretty significantly, and pretty rare in the Midwest. Probably healthier, maybe exercise more, maybe better diet. And Maryland, we're kind of like halfway. So who exercises in the United States? Well, when they studied it, the same areas really don't exercise too much, and these people exercise a lot. You can imagine Californians, people in Denver, and in this Midwest. Maryland, we're kind of like a mix. How about within the state of Maryland? Who has diabetes? Well, Baltimore City is very high incidence, PG County. Harford County, we're kind of in the middle, so we're not as healthy as Montgomery County and Carroll County.
What's the other one? Dorchester?
I don't know, what county is that? Pete, do you know what county that is?
Cambridge?
I'm not sure.
It's not Ocean City.
No.
Yeah, there's a lot of diabetes there in the Eastern Shore. And where are the people overweight in Maryland? Well, PG County again. Harford County is not doing so well. We're a little bit overweight. And Baltimore City is not doing so well. So Harford County, we should know about ourselves. Our obesity rate is 28.3%, and in the United States it's 26%. So we're a little worse than most. Our diabetes rate's a little less than the national rate of 9%. We're 8.3% nationally. We're a little bit worse of 9%. So we're about the national. Harford County is about what everyone sees across the country. So a third of all people are pre-diabetic. So that's a lot of people. And pre-diabetic being you're not by strict definition diabetic, which is, I think, the strict definition is hemoglobin A1C greater than 6.5, fasting glucose is greater than 125, and any glucose, I think, is around 200. I may be wrong with those numbers, and then you can also do a glucose tolerance test. But you're not normal. So pre-diabetic is you're not normal, but you're not diabetic where you need to be treated, but you're pre-diabetic. So that's a lot of people, a third of people. And we'll go over this actually. So the pre-diabetic people, well, another way to understand this is called metabolic syndrome. So the reason why you should know this is because pre-diabetic people and metabolic syndrome people are a lot more likely to get diabetic peripheral neuropathy. And the risk factors are waist circumference greater than 40, triglycerides greater than 150, a low HDL, hypertension, blood pressure, and abnormal fasting glucose. And for women, the waist is different. It's 35. I can't mean you don't have a 35 waist, do you? You're a lot less. Yeah. Okay. So diabetic peripheral neuropathy, they have pain. That's one thing they can have. And the way we measure pain, we can ask them with words, or we can use the visual analog scale from 0 to 10, a 10 centimeter scale, and that way we at least get a number to understand where the pain is. It kind of helps us track it and do research, etc. So 0 is no pain, and 10 is the worst possible pain. The other way you can measure it is the Likert scale, which, do you use a Likert scale, Pete? I don't know. He created this scale, and you probably have seen it before, where they ask something like, do you like the Ravens? Or the Ravens are the greatest team in the world. And on the left is strongly disagree, and on the right is strongly agree. So this is a very common way to give a scale to something. So diabetic neuropathy, 10% of patients have neuropathy when they're first diagnosed with diabetes, so just 1 in 10. But probably around half develop painful diabetic neuropathy after 25 years. And not all of them are painful. Maybe a quarter of them are painful. And the pain can have all sorts of different characteristics. We'll go over that. So 30% of all diabetics have neuropathy, and 50% will develop symptomatic neuropathy at one point in their lives. 12% of diabetics never tell their physicians they have neuropathy. It doesn't register for some reason. They don't tell them. And if you carefully examine people that have had diabetes for greater than 20 years, 90% of them have some kind of abnormality within their nervous system. So there are different types of diabetic neuropathy, and today we're going to talk about mostly distal symmetric polyneuropathy, which is the most common one. But it can present in many different ways. Small fiber neuropathy, that's just a pain. Radiculoplexopathy, so the whole plexus can have an abnormality. So the lumbar plexus or the cervical plexus. It can be just a radiculopathy of one dermatome, which is unusual, or mononeuropathy, say of a cranial nerve or in the eye. So you can just have a diabetic. Have you ever seen that, Pete?
See, I don't deal with this at all. I don't really deal with it. I know nothing at all about it, so I can't ask patients about diabetes and stuff like that. But I mean, I do see conditions that may be what you're showing me, but I'm not aware of what I'm looking for.
And sometimes the patients present with an ocular palsy. Their eye just doesn't work, and it's from diabetic neuropathy. So the most common one is a diffuse symmetric, it's length-dependent injury to the peripheral nerves. So the one on the left is the most common, and where their foot feels numb and it goes up their leg, and they say it's in a stocking distribution. So it's not in the dorsum, it's not big toe, it's not plantar, it's not lateral foot, which is S1. It doesn't run down their leg. It's like their whole sock area, the whole foot circumferentially has an abnormality, and it's usually numbness, but it can be tingling too. But it can present also in other ways that can fool us. It can be on just one side, like a mononeuropathy multiplex, and in just the hands. It can overlap. This is what we usually see: distal symmetric polyneuropathy, with both feet and both hands are affected. And usually the feet are affected a lot earlier than the hands are affected. There are many other. So it can affect any part of the body almost. So we know the peripheral toes and feet. But it can also affect the autonomic system. We'll go over that. It can also have proximal tracts, so it can give you thigh pain, hip pain, buttocks pain, and it can have focal problems like eyes, ears, facial muscles. So it's very variable, which is kind of fascinating, because a lot of times these people, nobody knows what it is, and I think it's diabetic neuropathy. And it can affect all sorts of different nerve fibers that can give all sorts of different abnormalities. It could be sensory loss, thermal loss, allodynia. Patients are very sensitive, so if you touch their skin, it's kind of like reflex sympathetic dystrophy. They're more tender than usually. The reflexes can be out, and also you can have a motor deficit. So this is just a reminder that usually it's stocking glove distribution. So if you put on your sock, the same area where your sock is, those are pictures of Cammie's socks she sent me. The area where your sock is numb, or can be painful too. And same thing as the glove. Some patients say it feels like their sock is bunched up in their foot. So they say, my foot feels weird, like something's in there or something's abnormal. And that's more of a painful condition, not just numb, but painful. So other symptoms, so numbness, so they just can't feel it. And some patients don't even realize that their feet are numb. They have no idea. Some patients describe it as a burning sensation. Some patients say it's an electrical sensation, like a shock in their foot in the area. Some patients say it's a stabbing type sensation, like a sharp knife. And some people say it's allodynia or hyperalgesia. It's just very, very sensitive. The toe's very sensitive. And some patients just present with weakness, motor weakness. So like a foot drop, or the toe doesn't lift up, or yes.
Sometimes I get like that feeling in my feet, but it's usually from just being cold.
Being cold?
Yeah, like
what do you feel?
I'm numb and just like
your feet feel numb?
Cold, yeah. Like even
when you're cold?
Yeah, even like in my house with the AC, like just because I think my body starts to adjust, but my feet get.
Your feet feel cold.
Oh, and in the OR too.
Mm-hmm. Okay.
Do you think I have it?
No. I think you're just Cammy. And sometimes the patients have pain at night. So so the reason why I think they have pain at night is because it's at night when you're at rest. You don't have any other distractions in your life that painful conditions are brought out. Same thing with tumors. Good morning, Doug. Come on in. Same thing with tumors. Same thing with bone fractures. You get night pain. And diabetics quite often to me anyway, say I can't sleep at night because I can feel this tingling, burning sensation. Have you ever noticed that, Dave? Or
how about the so-called Charlie horse? Like, you know,
what is a Charlie horse?
When you get muscle spasm in the legs, it's very painful.
Spasms?
And you have to
like restless
get up,
leg syndrome.
Put weight on it, flex, dorsiflex, and whatever. And how is named Charlie horse? I don't know.
I don't know who Charlie is. Yeah.
You've never heard the term?
I heard Charlie horse while we were playing sports, and you get like a very sharp spasm in your thigh. They say it's a cramp or a Charlie horse.
At nighttime, physiologically, all soft tissue swells. So if you've got a problem like we're discussing here, and the tissue swells, it's going to make it worse. So that could be contributing to the symptoms also.
Mm-hmm. Okay, so so you may say, so this is, I just found this quote today. It said, Muhammad Ali said, "It isn't the mountains ahead to climb that wear you down, it's the pebble in your shoe." Now, it's kind of interesting. So pebble in your shoe. So if your foot's numb, now you can imagine when you go for a walk, let's say, Aaron, when you walk with your children and you have a pebble in your shoe, what do? You just finish out the walk and take the pebble out at home? You stop immediately, right? It's really bothersome. And if you're diabetic though, you don't feel that. So you just basically never even take the pebble out of your shoe because you're numb, and it can just really rip your foot apart, and you don't even know it. So that's the problem with these diabetic patients, is that they're insensate. So the first inclination you would say is like, so what if you're numb? It's good, so you don't feel pain. But quite the opposite. Pain is very, very important so that we don't destroy ourselves. So this like stepping on a bunch of glass, I've seen that before. I remember I was an orthopedic intern. There was a woman who just stepped on glass and didn't realize it. And there was glass on her foot. She put it in a shoe and she walked around like that for an entire day.
Who was your model for the picture?
That was Erin when she was applying for the position. She had to do a couple things.
Tough company, huh?
Yeah. Well, she needed to work real bad, so decided to do it. And you can imagine if you keep weight bearing on this insensate problem, you can basically start destroying your foot. And the ulcer is not a problem, but then it can just continually get worse, get infected, osteomyelitis, and then it becomes a very, very serious problem that eventually could lead to loss of the foot. The other thing that these diabetic peripheral neuropathy patients can develop is a Charcot arthropathy, and you may say, well, what's that? Does anybody right now have a microfracture in their body? So what happens is, let's say you go for a 10-mile. How about you, Cammie? You run a lot. You have a microfracture. Anything hurt right now?
I broke my big toe, but that was a long time ago.
Anything hurt? Like your foot hurt? So let's say you're a runner. You're quite often, like when you're a runner, you're like, my knee doesn't feel right. And you just stop for 3 days, and it goes away, and you start running again. So, and it happens to me all the time. I think it happens sometimes in the spine. You just got a tiny little microfracture. You stop, and it goes away. But these diabetics, they don't feel that. They don't feel these microfractures. So they keep fracturing their bones, and they don't stop walking. And they can destroy their joints. And when people who don't understand what this process is, they see it, they think it's like a tumor, they think it's an infection. It's not. It's a very slow, destructive process of the joints that they just can't feel it. And eventually you may need an amputation if it gets worse. Other things you get are autonomic neuropathy. So the autonomic system controls functions that are not voluntary, and those are gastroparesis. So your stomach doesn't empty. Constipation, your bowels don't empty because the nerves are affected. You can get a urinary retention. Same thing with your bladder. Your bladder doesn't empty properly. You can have sexual dysfunction, and you can also have electrical abnormalities within your heart. So you can have cardiac rhythm abnormalities. And the diabetes can infect the entire plexus of the lumbar spine. So you can have an unusual, diffuse, or sometimes asymmetric pattern of involvement. And you can imagine, like, you go see the spine surgeon, go see 1 million people, and everybody. The problem is, I think, is everybody has some abnormalities within their MRI of their lumbar spine, and a lot of people have unnecessary surgery because it was just diabetic neuropathy. Now, insulin does many things in our bodies, and one is it actually promotes growth and survival of neural cells. So the lack of insulin does lead to deterioration of nerve cells. So it's not just it's a metabolic process too. So the lack of insulin causes some level of deterioration of the nerve cells. So you may say, well, how do you test the neuropathy? This is a 10-gram monofilament. It's like a tiny little piece of plastic, and you just push on people's skins, and you check the bottom of the foot. Doug, do you have a system that you use?
Yeah, it's called Semis Weinstein monofilament. It's usually 0.054 grams, and it's a fishing line. And basically, when it bends, it reaches the maximal pressure. So if they don't feel it when it bends, then they lack protective sensation in that area.
And the other is a tuning fork. Pete, do you have a way that you use a tuning fork?
No, just to see if they lose their vibration, just like they're doing there.
Mm-hmm. So you put your hand on the patient and the tuning fork and ask them when it's gone.
Yeah, compare the two sides.
Compare the two sides.
Compare the extremity, upper extremity, lower extremities.
Mm-hmm.
Usually, if there's a defect, it's going to be usually the lower extremities first.
Mm-hmm. So that's what I usually do. I put my hand underneath the joint, and I tell the patients when they say it's gone. I tell the patients I can still feel it. So and that kind of proves it to them too that they have a problem. So there's all sorts of things that can affect you, and these are all the different ways that you can test the nerve endings in your body. You can just pinch, which senses more pressure. A pinprick is a nociceptor of the thin fiber unmyelinated nerves. A light touch or feather senses touch, and you also have thermoreceptors in your nerves that are hot and cold. Do you do any of those? I know, Pete, you do a pinprick. You check pinprick.
Automatic. It's with everybody, yeah.
Yeah, pinprick and probably light touch.
Yeah.
Not easy to do hot and cold in the office. Other ways that diabetic neuropathy patients, so we discussed this one, the glove and stocking anesthesia or numbness or paresthesias, and we discussed the vibration sense. Some patients say they have allodynia or hyperalgesia where they can't even at night have anything touch their feet. They can also present with ataxia. So you've lost your position sense in your joints, and patients either may need a cane or frequent falling, which is like a serious problem. They break their hips. Loss of deep tendon reflexes, and also they can present as a foot drop or weakness in the eyes.
Yeah, that's the one thing that I'm getting right now. There are times where I'm taking a shower and I turn around and I'm getting ready to fall. I lose my sense of balance. I have no idea where I am in space. I'm getting grab a hold. So that's the beginning of what my condition is, manifesting symptoms like that.
So it affects proprioception.
Proprioceptive, yeah.
That's,
You can check that with your toe. You move the joint of the toe.
Right.
Right, and I think as people get older, though, they lose proprioception. So when you When I see a lot of cervical stenosis, and I test proprioception, I have them do different tests to see how agile they are, walk a heel-toe straight line like a tightrope. And in the 70s, is a lot to ask for someone to do that. I mean, that's where you're. Yeah. What do you think, Doug? Is like, I think everybody loses it somewhat, but some a lot worse than others. But I have seen kids, like I remember one man, a case I'll never forget my entire life. He kept going in and out of the ER. He's 20 years old with, he says his neck hurt, he couldn't walk, and they just thought he was a drug addict. Finally, someone got an MRI of his neck. He had severe spinal cord compression in his neck, and he could not walk. He was walking like he was drunk. He was only 20. And I could not believe it. So the next day I did a laminectomy, a multi-level laminectomy, and he came back 6 months later. He said he was running now for exercise. It's totally normal.
Total decompression.
Yeah.
What you had to do,
Yeah, totally normal. So ataxia is another position. So how do you treat this? So these are, I threw this in there. These are all different other types of neuropathies. Can anybody name some other things that can cause neuropathy? Who knows anything other than diabetes? Diabetes is the most common one.
Mentioned Lyme disease.
Lyme disease can cause neuropathy. Alcoholic neuropathy, absolutely. And I think the combination alcoholic neuropathy and diabetes is a terrible combination. Those patients are much, much worse. What else can cause a neuropathy?
Thyroid disease, either hypo or hyper. I think.
Thyroid disease. Okay. Anybody else know anything that causes peripheral neuropathy? How about like vitamins, like vitamin, was it B12? Or was it pernicious anemia? So vitamin B deficiency. Also, anybody can, chemotherapy can cause a neuropathy. I've seen that very, very often. Yeah. And any other neuropathies? There's also the hereditary ones, which we're not even going to go into, the Charcot-Marie tooth and the hereditary motor sensory neuropathies. Okay. The other thing that destroys nerve cells in diabetics is free fatty acids. So if you have high triglycerides and free fatty acids in your blood, the free fatty acids are neurotoxic as well. So here's a nerve under the microscope, and you can see the nerve has little blood vessels, and the blood vessels basically feed the nerve. The nerve needs oxygen. So what happens in diabetic peripheral neuropathy, here's a normal artery, or the vasonervorum, which feeds the nerve. In atherosclerosis, you have end capillary disease, so the nerves don't have a blood supply, and that's a very common contributor. So there's a vascular component to diabetic peripheral neuropathy, which is the same vascular component that gives these people strokes, heart attacks, etc. But also there's a metabolic aspect to diabetic peripheral neuropathy, where insulin promotes nerve growth, and also the free fatty acids we talked about, that affects it symmetrically. So it's kind of like a combination. And if the nerve does not have a blood supply, you can see this cartoon that the nerve shrivels and slowly deteriorates with time. So any questions about diabetic peripheral neuropathy, how it happens, how often? Okay, so quality of life. This is after Erin started working for me. She was sad, but this is afterwards. Her quality of life dramatically improved. She was very happy, and quality of life is, I'll put this so everybody can see it. So quality of life is social functioning, mental health, bodily pain, vitality, and sleep interference. So you want to improve these people's quality of life somehow. There's nothing you can do to take away diabetic neuropathy that I know of, other than in type 1 diabetics, tight glucose control helps with the disease process. But apparently tight glucose control does not help with type 2 diabetics. So I don't think there's anything that you can do to change the disease that I know of. The other obvious thing is don't become diabetic. So there are things that you can do, and now with gastric bypass, that actually is a surgical solution for type 2 diabetes. I mean, people's diabetes reverses with gastric bypass. So like, don't become diabetic is the only thing. But there also are medicines. Does anybody here have a medicine that they think is best? I'm going to go over all of them.
I start off with amitriptyline, which is also a Fexer, 10 milligrams at night. It's cheap. It's easy. I think it's probably generic and it's sort of the first line.
Yeah, amitriptyline is really cheap, and it's Merck. Amitriptyline came out in 1961, so it's been around forever. So we really know the drug really well. In high doses, it's for depression, but it's not used for depression anymore because you can very, very easily die from an overdose. So the problem is with these depressed people is they want to end their lives. So you don't want to give them something where they can do that very easily. So it's not used for depression anymore because of that. But it is used for a lot of other things, and diabetic neuropathy is a great one. When I was in residency, I always used 10, but apparently the literature says now it's 25. So the starting dose, what do you use, Doug, when you start?
10.
Yeah, when I was in residency, we used to use 10. How about you, Pete? Do you have a dose? The literature apparently, I think, is 25 is a better starting dose. But it can have dry mouth.
You can go up incrementally. I think it's one of those things where, if it helps a little bit, I sort of double it, but I just start at 10. After a while, it sort of gets out of my realm of comfort. If they need something a little bit more, I'll send to someone else. But
yeah,
I think it's something where I also use it occasionally if they have like a nerve injury, a traumatic nerve injury, and you can just sort of basically arbitrarily just increase it up to 100 without.
Yeah, that's what I do. I start at 10, and I say, look, you can double it, or I give them 25 sometimes. And you say you can double it after a couple weeks if it's not helping. And I usually tell them take it at night because it can cause drowsiness. The main complaint I've seen is dry mouth. A lot of people say just their mouth becomes really dry. Other risks are palpitations, hypertension, restlessness, fatigue, and increased intraocular pressure. And I think all of these medicines can cause intraocular pressure, so you don't want to ever give it to somebody with glaucoma. Another medicine that's Cymbalta is another treatment. So I think amitriptyline is a good first-line treatment because it's very inexpensive and it's a very low dose. Cymbalta helps as well, somewhere between 60 and 120 milligrams a day. It doesn't decrease tingling or numbness at all, though, but it does help with pain. Cymbalta also is FDA approved for fibromyalgia. You can't use it in glaucoma patients. It can cause nausea, somnolence. It came out in 2004 by Lilly. And another treatment is Effexor. I've never used Effexor myself. I have given Cymbalta. I've never used Effexor. Effexor came out in 1993 by Wyeth. Again, you have to be careful of glaucoma. It can cause pulmonary hypertension, nausea, somnolence, dry mouth, dizziness. So another type of medication is anticonvulsants. Does anybody here use Neurontin or gabapentin? That's a very common drug. Occasionally, sometimes. So Neurontin is a different class of drug. It's a anticonvulsant, and Neurontin came out in 1994 by Pfizer. And does anybody know about the Warner-Lambert legal action against the government? There's a legal action against Warner-Lambert in 2004 that they were encouraging doctors to prescribe Neurontin on an off-label basis. So it was not on-label, was not for pain. It was just for seizures, I think. And in 2002, they had it approved for postherpetic neuralgia. And
it's a really good nerve membrane stabilizer.
Nerve membrane.
It really helps them.
So the dose is anywhere between 900 and 3,600. And another possible option is valproic acid, but I don't have any experience with that. I don't think it's as good as Neurontin. Lyrica, or pregabalin, is similar to gabapentin, and it's a very common prescription for diabetic neuropathy. It's not generic, so it's a little bit expensive. It was approved for partial onset seizures and postherpetic neuralgia and neuropathic pain from spinal cord injury and diabetic peripheral neuropathy, and it's also FDA approved for fibromyalgia. In Russia, it's approved for generalized anxiety disorder, which is interesting. It came on market in the fall of 2005, and the patent expires in 2018. And the dosage for Lyrica, do you use Lyrica? Anybody here use Lyrica? I give it for neuropathic pain. I start at 75 twice a day, but I usually try amitriptyline first. It can cause drowsiness in 10% of people. So this is, who knows what this is? The poppy plant, yeah. So the fluid from the poppy plant is where opium comes from. Opiates are an option. I won't even get it. Does anybody have anything they want to say about opium as a use for pain for diabetic peripheral neuropathy? It's very addictive, and you get it's addictive, and also the problem is you get accustomed to the medication. So in about a year or two after starting opiates, quite often the pain is just as bad as it was when you started, and you have an incredible addiction. So it can be a problem. Tramadol is another medication. Anybody here use tramadol? What are your thoughts on tramadol, Pete? You think it works?
Yeah, I think it's effective at times, most of the time.
Okay.
If somebody's very obese or something, you got to be careful. It may not do anything, but the average patient does pretty well.
Yeah, it's an opiate derivative, so I don't think it causes the constipation but it does have dependency issues. Though some people do get dependent on it. So who uses Tabasco for diabetic peripheral neuropathy? So when I was in high school in the track team, everybody used Bengay. So if you had something hurt, we used to rub Bengay on it. This is like PG County. This is what we did. Did you use Bengay? Yeah. See, we're from PG County. We didn't have the money for like pills and doctors. We used Bengay. So what's the? Yesterday I saw a patient, a 75-year-old woman who had L5S1 spondylolisthesis. I said, yeah, the surgery is, big operation, 4 hours. There's all sorts of risks, hospitalization, screws. And she goes, well, I just take this menthol stick, she said, and I rub my leg, and my pain goes away. And I was like, how much is a stick? She said, 88 cents. I just bought it from Walmart. I was like, all right, well, when the stick doesn't work anymore, call me. So all these options are capsaicin, which is in our nerve endings, are unmyelinated pain fibers, and it basically distracts us from our painful conditions. So it's a very common over-the-counter remedy that may work. So you can tell people, just try at night, maybe try rubbing this on your legs, and it helps them with their pain. So, and the way that it works is another. I'll tell you how it works. It works with the gate theory of pain. Another thing that's been proven to work is nerve stimulation. So you just you break a pain cycle by just stimulating people's nerves once a day. Very similar to a TENS unit. A TENS unit is another thing that can help. So the way it works is it's the gate theory, where you have these pain guys, and then you have the TENS unit people, or the capsaicin stimulation. They all go to the spinal cord, where only one signal goes up to your brain for pain. So if you can somehow fool sort of the spinal cord into just sending up the capsaicin or the Bengay stimulus to your brain, you don't feel the neuropathic pain. So that's how all these things work. The Bengay, TENS units.
And acupuncture works in
Acupuncture.
some cases
Yeah.
because of this.
Yeah, acupuncture definitely works. Yeah. So there's nociception, and then there's a distractive stimulus like rubbing, massaging, application of pain, and they're different fibers. The small peripheral nerve fibers are the ones that nociception, the pain, and the large peripheral fibers are different. And once you get to the spinal cord, there's only so much that can go up to your brain. So that's the whole. This is the gate theory that they got a Nobel Prize for this. This is how it works to help people without surgery. There's also one more thing. I've never tried this, but in my readings, nitrate sprays help with pain. Has anybody ever used this? Isosorbide dinitrate spray. Apparently, it's effective for.
Yeah, some people use catapress patches also, topical stuff. Which I guess catapress is a fluid blocker or something. But, catapress is apparently like an approved use. I know like a lot of the hand guys use it a lot for like.
It vasodilates, doesn't it? I mean, I wonder if it just works on the gate theory. I don't know. Okay, so what do you do with people with diabetic peripheral neuropathy? So since we understand diabetic peripheral neuropathy, we're a lot more likely now to treat it, and we know what it is. So first, you can make sure there's nothing else that can be causing it, like chemotherapy. We talked about that. Make sure their glucose is under control. The first line treatment, some people say, is tricyclic antidepressants or nortriptyline. We talked about that. If that doesn't work, You can move on to maybe gabapentin, pregabalin, which is Lyrica. Topiramate is Topamax. Topamax is another, we didn't talk about it. Topamax is another medication that may have some benefit. If those don't work, another option are the serotonin inhibitors, which is duloxetine is Cymbalta. If that doesn't help, you can try tramadol or opiates, or you can also do combinations, but combinations is beyond my expertise. I'd send them to pain management. So does anybody else have...
You know, there's a guy who's made a living out of doing surgery for this. Plastic surgeon down in Baltimore where he does...
Lee Dellin.
Yeah, Lee Dellin. Does
He's
nerve decompressions.
He's the decompression treatment for diabetic neuropathy.
Yeah. He's written tons on it and...
Textbooks. Very smart guy.
Yeah.
He's a plastic surgeon. This is just the medicine route, but I think, me personally, after going over this, I'm a lot more likely to use capsaicin. And why not? It's inexpensive. It's $1 at Walmart. It's safe, and it may work. So that's it. Thanks. That's Ravens training camp. We're all excited. They're going to win another Super Bowl. So any questions or comments about diabetic peripheral neuropathy? Right, guys. Thanks for coming.